Imagine you're at the gym,
Okay.
you step up to the bar, chalk on your hands, and you're ready to hit a new personal best on the deadlift.
Setting the scene. I like it.
You brace your core, you lift, and right as you hit the absolutely hardest part of the movement, um, you leak urine.
Yeah, which is incredibly common.
Right. Or maybe you're just at a dinner party, someone tells a fantastic joke, you laugh harder than you have in months, and suddenly you feel that same unmistakable leak.
It completely derails your confidence.
It really does. And this isn't a rare occurrence at all. So we are diving into a stack of sources today to answer a very specific and surprisingly common question for you.
And it's a fascinating one.
Can an injection that was originally designed for sexual wellness, specifically the O shot, actually stop you from leaking urine during a heavy workout, a sneezing fit, or, a good laugh?
It's a question that sounds almost unbelievable at first glance. But before we get to the injection itself, we really have to look at the sheer scale of what we are dealing with here. Because the sources make it clear that urinary incontinence is, well, it's an absolute epidemic.
Yeah, the numbers blew my mind.
We're talking about an issue that affects roughly 13 million people in the United States alone.
13 million.
Exactly. And in the UK, the clinical data suggest up to 50% of women experience this at some point in their lives.
50%. That is half the population of women.
Right. Yet it remains almost entirely shrouded in embarrassment. Women are routinely told, or they just sort of assume, that wearing adult diapers or protective pads is just a normal part of aging.
Or they think it's the inevitable permanent price of going through pregnancy and childbirth. Like it's just a tax they have to pay.
Exactly. Which is incredibly frustrating to read.
It really is. You see these anecdotes in the source material of women completely restricting their daily activities.
Yeah, avoiding social gatherings.
Right, or entirely dropping the physical activities they love. The hit to their psychological well-being is profound.
It changes how they live their lives entirely.
So our mission for you on this deep dive into the source material is to break this all down. We're going to unpack exactly what stress urinary incontinence is, examine the traditional treatments available.
Some of which are shockingly invasive, by the way.
Totally. And then we'll look at the hard science behind how the O-shot is emerging as a non-surgical alternative.
Sounds like a plan.
To start, though, we really need to understand the underlying mechanics here. Why does a heavy deadlift or a cough lead to a leak in the first place?
Well, the clinical guidelines we reviewed are very careful to distinguish between the two most common types of incontinence. Because, treating them requires completely different approaches.
Right, they aren't all the same thing.
Not at all. You have urge incontinence, which is often tied to an overactive bladder, or OAB.
Okay.
This is primarily a nerve-driven issue. The detrusor muscles, which sit right in the wall of the bladder, they basically become hypersensitive.
So they're firing when they shouldn't be.
Exactly. They contract on their own far too often. That creates a sudden, intense, uncontrollable urge to go. Completely, regardless of how full the bladder actually is.
Okay, let's unpack this. If the bladder is a water balloon...
I love a good water balloon analogy.
Right. So OAB is like the balloon itself malfunctioning. The rubber is suddenly squeezing inward on its own, trying to force the water out, even if you just went to the bathroom like 5 minutes ago.
That captures the dynamic of OAB really well. It's an active malfunction.
Got it.
But stress urinary incontinence, or SUI, which is the actual focus of our sources today, operates on a completely different physical principle.
Okay, so how does SUI work?
SUI is an anatomical structural failure. So underneath the bladder and the urethra, you have the pelvic floor muscles, specifically the levator ani.
The levator ani.
Right, and a crucial web of supportive tissue called the endopelvic fascia. You can basically think of this fascia as a strong, fibrous hammock holding the entire urinary system up.
But the issue arises when that hammock starts to, fray.
Exactly.
Yeah.
The sources mention this happens due to a huge variety of factors.
Like what?
The physical trauma of childbirth is a big one. Hormonal changes during menopause, advancing age, obesity, or even just having a chronic cough that constantly strains that specific area.
And that strain is all about intra-abdominal pressure, right?
Yes. When you cough, laugh, or brace your core for a heavy lift, you are drastically spiking the pressure inside your abdominal cavity. It's just basic physics.
So that pressure pushes down on the bladder.
Right. And if the supportive hammock beneath it is weakened, it gives way slightly. That downward force overpowers the urinary sphincter, the valve that's supposed to keep the urine in, and boom, you get a physical leak.
Okay. To bring back the water balloon,
Yes, let's do it.
SUI isn't the balloon squeezing itself. SUI is someone stepping on the balloon from the outside, while the knot at the bottom is resting on this flimsy surface that can't provide enough resistance to keep the knot sealed.
What's fascinating here is how this purely mechanical view of the problem completely shifts who we assume suffers from it.
How do you mean?
Well, because it's driven by physical pressure. This is not just an issue for postpartum mothers or elderly women.
Right.
The sports medicine studies we looked at explicitly note that SUI is highly prevalent among extremely active recreational gym goers.
Really?
Yeah, very fit women who do heavy weightlifting, CrossFit, or high-impact cardio are suffering from this specifically because they are routinely generating massive amounts of intra-abdominal pressure.
Wow. Which puts an active listener in a terrible bind. I mean, if you're an avid gym goer, the last thing you want to do is stop lifting weights or give up your sport entirely.
Exactly. It's an awful choice to have to make.
So, if the problem is a weakened structural hammock, how does the medical field currently try to fix it? Because reading through the traditional options in the clinical guidelines, the choices seem pretty stark.
They are. The traditional medical toolkit is heavily polarized.
Okay.
On one end, you have highly conservative, non-invasive approaches. The absolute first line of defense is typically weight loss and pelvic floor muscle training.
Okay, so diet and exercise, basically.
Right. And the data on weight loss is actually quite strong. One study showed that for obese women, just an 8% reduction in body weight dropped their leakage episodes from 47% down to 28%.
That's a huge drop from just an 8% weight loss.
It is. It simply reduces that resting downward force on the pelvic organs.
And the muscle training, those are essentially Kegel exercises, right?
Basically, yes.
I know the sources mention technological aids for that, like the Emsella chair.
Yeah, the Emsella chair is interesting. It uses electromagnetic energy to force your pelvic muscles to contract thousands of times in a single session.
Wow. Just sitting there.
Exactly. And biofeedback physical therapy can also be highly effective for strengthening the levator ani muscles. However, muscle training alone has real limitations.
What kind of limitations?
Well, it requires intense daily discipline. And if the endopelvic fascia, the actual connective tissue of the hammock, is physically torn or severely degraded, strengthening the muscle around it might not be enough to completely stop the leak during, say, a max effort deadlift.
That makes sense. Which leads right into the other end of the spectrum, which genuinely surprised me when I was reading the sources.
The surgical options.
Yeah. If you move past the conservative options, the interventions become intensely invasive very quickly. We're talking about synthetic bulking agents and major surgery.
Right. So,
Okay, injecting a synthetic paste that might cause painful inflammatory nodules sounds like an absolute nightmare scenario.
it's definitely a serious risk.
And yet the alternative surgical options don't seem much better.
No, they don't. The surgical gold standard for SUI is the mid-urethral sling.
Okay, what is that?
A surgeon goes in and physically installs a new hammock under the urethra to support it. To do this, they either harvest autologous tissue, meaning they literally cut a strip of fascia from the patient's own thigh or abdomen, or they implant a synthetic mesh sling.
Let's pause on that for a second. The options for the listener are essentially spend months doing thousands of Tegels and hope the tissue isn't permanently torn,
Right.
inject synthetic gels that might cause granulomas, or undergo major surgery where they carve a piece out of your side to build a new hammock.
When you lay it out like that, it sounds incredibly grim. And we have to be clear about the outcomes of those surgeries, too.
Are they at least effective?
They are highly effective at stopping the leak. About 66% of women are completely dry post-operation.
Okay, that's good.
But the morbidity risks are significant. Up to 10% of women develop chronic, long-term pelvic pain following sling surgery.
10%. That's a huge number for chronic pain.
It really is. Some experience urinary retention so severe they have to use disposable catheters at home just to empty their bladder.
Oh my goodness.
And the controversies surrounding synthetic mesh are well documented. Over time, the mesh can physically erode through the vaginal tissue, requiring highly complex removal surgeries.
The gap between those options is just staggering. You either commit to an exhausting daily regimen of exercises with a hard ceiling on their effectiveness, or you expose yourself to permanent, life-altering surgical complications.
It's a massive canyon in the standard of care.
And that gap is exactly why our source material is focusing on this new regenerative approach.
Exactly. The demand for a minimally invasive middle ground is what drove clinicians to look at treatments from entirely different fields, which brings us to the O shot.
Right. And we should probably clarify the origins of this right away. The O shot stands for the orgasm shot.
Yeah.
It was originally designed entirely for female sexual dysfunction. The early clinical focus was on helping women dealing with vaginal dryness, low libido, and difficulty reaching orgasm, particularly in postmenopausal or postpartum patients.
Right, that was the initial intent.
But doctors began noticing a secondary effect regarding incontinence.
And to understand why a sexual wellness shot affects urinary incontinence, we really have to look at the foundational science of what is actually in the syringe.
What are we actually injecting?
The O shot relies on platelet-rich plasma, or PRP.
PRP, okay.
This places it firmly in the category of regenerative medicine, totally bypassing synthetic gels or plastic meshes altogether.
I want to make sure we get the mechanics of this right for the listener. The sources outline the procedure starting with the standard blood draw from the patient's arm, similar to any routine physical.
Very straightforward, yes.
That vial of blood goes into a centrifuge. Now, what is the centrifuge actually doing to the blood? Are we just trying to filter out the red blood cells?
That's the first step. The centrifuge spins the blood at an incredibly high speed. Because the components of our blood have different densities, the physical force naturally separates them into distinct layers.
Like oil and water.
Exactly. The heavy red and white blood cells sink to the bottom. What is left at the top is the plasma, this golden fluid known as the supernatant.
Okay, the supernatant.
Right. But crucially, this spinning process traps the platelets in that plasma at a massive concentration. We are talking about isolating a fluid that has more than 4 times the normal concentration of platelets found in regular circulating blood.
Okay, so we have this highly concentrated golden liquid. Why are platelets the star of the show here?
Platelets are the body's first responders. Whenever you get a paper cut or tear a muscle or sustain any internal injury, platelets rush to the site.
To stop the bleeding, right?
That's their first job, to clot the blood. But their second, far more important job is to initiate the healing process. Platelets are essentially cellular powerhouses, packed with biological signaling molecules.
The sources list a whole alphabet soup of these molecules. Glycoproteins, chemokines, cytokines, various growth factors.
Yes, lots of technical terms.
But rather than getting bogged down in the textbook names, what are these signals actually doing in the tissue once they get there?
Think of them as a biological alarm system combined with an architectural blueprint.
I like that.
When concentrated PRP is injected into tissue, those platelets release their growth factors. These signals permeate the surrounding area and seek out dormant stem cells.
Stem cells that are just hanging out, waiting.
Exactly. Specifically, they activate unipotent stem cells that already exist in the tissue but are inactive. The growth factors wake these stem cells up, instruct them to migrate to the area of need, and direct them to begin repairing damaged cells and generating entirely new, healthy tissue.
Here's where it gets really interesting, because we are talking about injecting this concentrated plasma to fix a mechanical leak. If the problem with stress urinary incontinence is a loose sphincter and a weakened hammock, how does waking up stem cells actually stop urine from escaping during a heavy lift?
The key is where it's injected and what specific process those stem cells initiate. In the clinic, the physician applies a strong topical numbing cream, followed by a local anesthetic block.
Okay, so the patient is numb.
Yes. Once the patient is comfortable, the concentrated PRP is injected directly into the clitoris and the anterior vaginal walls. The specific target here is the tissue immediately surrounding the urethra and the bladder neck.
So we are putting the platelets right next to the failing structural hammock.
Yes, exactly. And once the platelets release their signals in that specific location, they trigger a biological process called angiogenesis.
Okay, angio meaning blood vessels, genesis meaning creation. So the creation of new blood vessels.
You got it. Angiogenesis brings a massive influx of fresh blood flow, oxygen, and nutrients into the weakened endopelvic fascia.
Feeding the tissue.
Exactly. This increased blood flow stimulates fibroblasts, which are the cells responsible for producing collagen and elastin. As new collagen is laid down, the tissue physically thickens.
Oh, wow.
The vaginal walls become plumper and more robust. This natural tissue regeneration restores the structural integrity of that hammock, holding up the bladder.
It's completely rebuilding the resistance from the ground up.
It really is.
If we go back to the synthetic treatments, the bulking agents were just stuffing a foreign paste into the wall to block the hole. The surgical mesh was shoving a piece of plastic under the urethra to prop it up. But this is completely different.
It's a totally different philosophy of healing.
It sounds like instead of propping up a collapsing roof with a temporary wooden beam, we're actually convincing the house to grow its own new, stronger walls.
If we connect this to the bigger picture, that is the defining advantage of regenerative medicine. By harnessing the body's innate evolutionary healing mechanisms, you completely sidestep the cascade of risks associated with traditional surgery.
Because there's no foreign material?
Exactly. There is no synthetic mesh to erode into the vaginal wall over time. There are no synthetic bulking agents for the immune system to attack and turn into granulomas.
It's just you.
You are using autologous material blood that came from you, processed, and returned to you. The immune system recognizes it entirely as self, so the risk of rejection or allergic reaction is practically zero.
The underlying science is fascinating, but for the listener who might actually be dealing with SUI, we really need to talk about the reality of the treatment.
Sure, the practical side.
What does this actually look like in practice? Because if you're comparing this to a surgical sling, the recovery time has to be vastly different.
Oh, the procedural reality is night and day. The entire O-shot process, from the initial blood draw to the final injection, is typically completed in an outpatient clinic in under an hour.
Under an hour? That's incredible.
And despite the injections being in a highly sensitive area, the combination of topical creams and local anesthetic means patients consistently report the procedure is highly tolerable.
So not a ton of pain.
No, they often feel just a mild pinch or pressure.
And what about downtime? A mid-urethral sling requires weeks of restricted lifting and avoiding strenuous activity.
With the O-shot, the downtime is virtually non-existent. In fact, one of the medical resources we reviewed detailed a specific case study of a female patient who was an avid weightlifter.
Okay, I remember this.
She had reached a point where her SUI was entirely dictating her gym routine. She couldn't do heavy squats, she couldn't skip rope, and the constant anxiety of leaking was basically ruining her workouts.
Which so many listeners can probably relate to.
Exactly. Well, she received the O-shot in the afternoon, noted a brief, minor stinging sensation as the anesthetic wore off, and went back to her gym that exact same evening.
Wait, really? She lifted on the same day as the procedure?
She didn't just lift, she hit a personal best in the deadlift without a single drop of leakage.
That is an incredible anecdote, but I want to make sure we are setting realistic expectations here based on the clinical literature.
That's fair.
Because a biological process like angiogenesis and collagen production doesn't happen in a few hours. So how could she possibly be leak-free that same evening?
It's a very vital distinction to make. In the immediate aftermath of the injection, the sheer volume of the plasma fluid being introduced into the tissue provides a temporary mechanical bulking effect.
Ah.
That immediate fluid volume can offer structural support right away, which is likely what allowed her to deadlift that evening. However, that fluid is absorbed by the body relatively quickly.
So there might be a brief window where the mechanical support fades before the biological support really kicks in?
Precisely. The true biological regeneration, the creation of new blood vessels and the laying down of dense collagen fibers, takes time. Clinical observations show that the growth factors usually begin making a noticeable structural difference around 2 to 3 weeks post-procedure.
Okay, 2 to 3 weeks.
And then the results continue to compound, typically peaking around 3 to 4 months.
And how long does that new structural integrity last? I assume because our bodies are constantly aging and under physical stress, this isn't like a permanent cure forever.
No, it's not permanent. The constant intra-abdominal pressure of heavy workouts will eventually wear on the tissue again. Clinical data suggests the structural benefits of the O-shot for incontinence typically last between 12 to 18 months.
At a year to a year and a half.
Right. But the significant upside, however, is that because the treatment uses the patient's own biological material without any synthetic additives, returning for a maintenance injection a year later is completely safe.
Because you aren't building up scar tissue or accumulating plastic in the body?
Exactly. You're just giving the tissue another boost of your own growth factors.
The sources also point out a factor that makes this entirely unique among medical treatments for incontinence.
The secondary benefits.
Yeah. Because the O-shot is injected into the clitoris and the anterior vaginal wall, and because it was originally designed for sexual dysfunction, treating the SUI also triggers all of those original sexual wellness benefits.
Yes. The angiogenesis and increased blood flow don't just thicken the tissue to support the bladder, they systematically upgrade the health of the entire vaginal region.
It's a 2-for-1.
It really is. Patients undergoing the procedure purely to stop leaking during exercise frequently report significant secondary effects. We're talking increased natural lubrication, heightened sexual sensitivity, stronger orgasms, and a tighter vaginal opening due to the restored collagen.
It's a complete paradigm shift from how we normally view medical interventions. Usually, they are hyper-focused on fixing one singular symptom, often at the expense of causing a negative side effect somewhere else.
Like the chronic pain from the mesh.
Exactly. But here, the side effect of treating incontinence is revitalization of sexual health.
This raises an important question for the listener examining these sources. What is the true cost of an injury? Treating SUI isn't just about stopping a physical leak of urine.
Right, it's so much more than that.
It is about a holistic restoration of a person's life. It restores women's confidence to jump on a trampoline with her children or to brace for a heavy lift at the gym without constant anxiety. It addresses the emotional toll, the social isolation, and the physical degradation all at once, purely using the body's own materials.
To bring all of these sources together, we've established that stress urinary incontinence is a mechanical failure. The hammock of the pelvic floor gives way under intra-abdominal pressure.
Simple physics.
And for decades, the medical field basically offered a brutal choice between endless Kegel exercises or highly invasive, risky surgeries involving synthetic meshes.
A terrible choice to have to make.
But regenerative medicine has introduced a bridge. By drawing a patient's own blood, concentrating the platelets, and injecting those growth factors directly into the weakened tissue, the O-shot triggers the body to grow new blood vessels.
It lays down fresh collagen.
Right, and biologically rebuilds its own structural support, all with zero downtime and a host of sexual wellness benefits.
The clinical shift here is profound, and it leaves us with a really compelling thought.
What's that?
We've seen how concentrating our own blood plasma can literally rebuild the failing structural integrity of the pelvic floor, turning a loose, leaking barrier back into a tight, functional seal.
Right.
It makes you wonder if our own blood carries the architectural blueprints to repair something as complex and mechanical as the endopelvic fascia. What other inevitable wear and tear structural problems in our joints, our spines, or our ligaments might we soon be able to cure simply by isolating and redirecting our own internal healing factors?
Wow. It really changes how you look at the future of medicine. Maybe the ultimate medical toolkit isn't about finding the perfect synthetic material to implant.
Maybe not.
Maybe it's just about learning how to give our bodies the exact instructions they need to rebuild themselves so you can get back to living your life. Whether that means laughing until you cry or finally hitting that new personal best on the deadlift, completely leak-free.